So the pillar 3 is eliminating malaria, and we also say shortening the end game. I'm a very competitive person, so I'm going to say we should not just end the game, we need to win it. And so how are we going to do it? We have different challenges that we're facing with malaria, and when I think about malaria elimination, some of you have seen it in one of the slides I presented this morning. I like to think about elimination as a puzzle. It's a jigsaw puzzle. There are many pieces in there, but maybe from an MMB perspective, what I would like you to bring home is 3 pieces of this puzzle. It's other strain other than falciparum. So we need to think about Vivax, Ovali, malaria. Women, pregnant women, together with children, of course, and transmission blocking. So Dr. Daniel Joy has mentioned all the challenges that we're facing in this jigsaw puzzle to eliminate this disease. We have health system that needs to be strengthened. We have the resistance, drug resistance, vector resistance, insecticide resistance. We have funding that is shrinking, or at least is stalling, and is not good news for us. There's a spread of vectors that are very adaptable. So we have seen in the WHO report how the threat of Anopheles defensi is actually posing a huge challenge and could pose a challenge. It's coming into Africa, and it does adapt into urban settings, which is not good news considering that we want to increase urbanization. And then we have climate change. Daniel mentioned it. This is another huge threat. It's a reality. We hear about climate change day in and day out. People think that, some people think that it's not a reality, but it is real. And so we're seeing that the vector is surviving at higher temperature. We are seeing that actually, as Daniel said, we have areas that were malaria-free that actually are seeing insurgence of malaria. And we have a disaster like flooding. We've seen it in Mozambique, we've seen it in Uganda, and we've seen a huge rise in cases of malaria. So if we go back to those 3 pieces of puzzle that I would like you to concentrate on, other strains, why is it so important? After my talk this morning, I had Dr. Daniel Yilma, is one of the PI we've worked with in Jimma, in Ethiopia. And so he said, I'm so glad you talked about Vivax, because usually in Africa we don't talk about Vivax. But Vivax is there. We had another researcher that came to our booth and said to us, I'm from Senegal, I'm glad you talked about Vivax. We do have Vivax cases. So if we are thinking about eliminating this disease, we need to think about other strain other than falciparum. Falciparum is very important, but Vivax is as well. Ovali is as well. We have hotspot of Ovali, mixed infection, malaria. And so we have the success story of bringing into the market the first single dose tafenoquine for Vivax with GSK. That was a beautiful collaboration, again, collaboration and partnership. Yet we haven't got rid of the G6PD liability. And so we still need to test prior to administer. And that is not an easy thing to do. So in research, what we are doing is that we haven't abandoned Vivax, although we've been told, maybe concentrate on falciparum, but we haven't. And so, with this undercurrent things, we have kept platform working on Vivax, and so we have now for the first time 2 new chemical series that could tackle the anti-epinozoites, which is a beautiful dormant form of the parasite that remain dormant in the liver, with no G6PD liabilities. So we screen all our compounds for G6PD liability, and we bring on only those that do not have this liability. Women, Viveka nicely said it. We need to think about women. Children is absolutely one of our top priority, and pregnant women. And women are also another priority. They're a huge underserved population, and in order to eliminate this disease, we need to have medicine that can be safely administered into pregnant women of all trimesters. And so what are we doing into that respect? If some of you was attending our MIMBA session yesterday, you've seen how we're going from end to end, from prospective studies using drugs that are available today and trying to fill in the data gap that we have in terms of safety data with these compounds, And if we go down to the left in research, we're also implementing studies and assays that usually are not done as early as, before first in human, for instance, to make sure that we are able to screen molecule, to flag molecule that could not be, for instance, administered to women of childbearing potential, and prioritize compound that actually can, in order to fill the gap that we have in terms of medicine for that underserved population. Last but not least, I think one of the major pieces of this puzzle is also the parasite loads that we have in human bodies. So I attended once a seminar that was talking about eradication of diseases. And so there was this professor that talked about smallpox eradication. That's one of the major success we have had in global health, in any disease. That was the disease that was eradicated. And he said something very interesting. He said it was easy, actually, because we could go in the most remote village, in the most remote places on Earth, and we could find the last standing individual that had smallpox. Why? Because there was a clinical manifestation. Malaria is different. Any of us here in this room could be an asymptomatic carriers. So how do we treat, how do we eliminate the disease when actually we can't see it, that that person is carrying parasites? And so we can tackle it in two different ways. We're talking about transmission blocking. We can block it from a host perspective, so having molecule like ganaplacide, like carbamazepine, that can actually that are potent against gametocytes, so those sexual stage of the parasite that actually are going to reinfect the mosquito. So we can block the cycle there. Or, if we're going to be bolder, we can actually think about having the host that becomes the drug for the vector. And so we can stop it from a vector perspective with drugs that target the mosquito and they kill it. We've seen that there are mathematical models that are showing that actually this could be a strategy that could have a huge impact in stopping transmission, particularly in certain areas. So before handing over to Professor Isaka Sagara, that is here with us today, I just want to leave you with the message that this is a jigsaw puzzle. It's difficult, it's complex, yet if we do work together as a community from all the different angles and we commit to it, I think we can win this game. And I'm very pleased to introduce you Professor Isaka Sagara. He is the research director at MRTC in Bamako. We have a long-standing relationship with the Institute and with Professor Sagara. We've collaborated in many trials, and we aim to continue to do so with one of those new endectocides that we are trying to develop for transmission blocking. Please welcome Professor Isaka Sagara.
Thank you very much, Christina, for introducing me. Also, thank you, MMV, for inviting me to this symposium. And, of course, really the MIM society for organizing. So here, MMV asked me to talk about breaking the life cycle, as you can see on one part of their here box. So for malaria parasite, of course. And here, I will be talking on two parts in breaking that life cycles. First will be about drugs, and the other will be about transmission blocking vaccines. So for the drug parts, it will be these different studies called Nectar studies. So name of the studies, different studies, 4 studies done in Mali, led by Professor Diko and funded by Bill and Melinda Gates, and with different other partners at London School led by Chris Drackley, and also at Radboud, Netherlands, by Ten Busman. So most of those studies are already published, of course, but here about life cycle breaking, how. And the study design is that used all the almost ACTs, artemisinin-based combination used on ground, dihydroartemisinin piperakine, artemether lumefantrine, pyronaridine artesunate, and also used on ground also the prevention for children, SMC drug, sulfadoxine, pyrimethamine plus amodiaquine. So all those different drugs were compared with a control. so a placebo control for effectivity. So to do so, we screen more 1,000 and then have people who are carrying gametocyte, 10 years and over age group participants have been selected, and then compare with different. So in summary, what will this study show? In summary, different, and also in addition to the ACT alone, the primakin has been added as an additional arm, or even another also gametocytic drug, tafenoquine has been also added and tested. So in summary, using this, what we can say is that in any of those ACTs, when you use primakin at a relative low dose, then you block transmission, reduce or block transmission, starting 48 hours, let's say 2 days after you block transmission, and when even you follow up to 28 days, no effectivity proven using what we call a membrane feeding assay. So that for a different ACT when you add primakin. So when you don't add primakin, then at least we have shown that artemether lumefantrine is still blocking, and even if you add primakin, difference is not really significant, meaning that artemether lumefantrine alone is kind of, in terms of blocking transmission, is seen better. So that's the summary. But when this is with, if you add primakin, as I said, but if you add the tafenoquine, then it's block also transmission, but slower compared to primakin added on top. So SPAQ, artesunate amodiaquine, sulfadoxine pyrimethamine amodiaquine, also similar like ACT, really you can see that the blocking activity is not seen really, because like the ACT, we have shown effectivity starting and lasting more than 14 days for like ACTs if you don't add primakin. So, but if you add primakin, you can see the blocking activity even with SP and AQ. So, and that's the summary for that study. And quickly go back now to the blocking that transmission using the transmission blocking vaccine. Here, this study is funded by ADCP2 program. We thanks for, and they funded our consortium called the PF-TBV. Consortium led at the University of Bamako with different West African countries. Some are here in this room. And the specific candidate that we used that I will be talking is about a PFS 230 D1 antigen. So in summary, we took school-age children or adolescents starting 9 to 18 years old, and then vaccinated a series of vaccinated, 3 doses, and then after do at this time direct skin feeding assay. So, and also even boost 1 year again and did the same. So in summary, here we had, we did around on about 400 participants, and then we have seen that we are able to block around 75% of blocking transmission. And mosquitoes, when you look on blocking mosquitoes transmitting, 86%. So that's the summary of the result. And for each of those strategies, next step are, for transmission blocking, now consideration and combination with R21 is planned, and hopefully next month we will start phase 1 vaccination in Mali. For the drugs, very also next step is now with what we call the indectocid, so long life drug, that will be used to see how also this can be studied and block that transmission for a long period. So that's the direction for future. Thank you for your attention.